Hi, everyone. Okay, so I know that this is something that we come across a lot on the floor, so I wanted to talk about it. We're going to basically go over cirrhosis and the main decompensation clinical scenarios that we see in the hospital setting, okay? Let me actually make this. Okay, so the things we're going to go through overall is what's the natural course of patients that are diagnosed with cirrhosis, and how we want to manage those initially. And then just some updates, and we're probably going to go over those as we go along with each specific complication that we talk about. And the last couple of things is, which will be quick in the end, is when you think it's time to refer a patient for liver transplant. And we're going to discuss briefly the preoperative risk assessment, because we do come across that rarely in the MC rotation when you guys are called for POMAs. So the natural history is basically patients that develop chronic liver disease from whatever etiology. It could be alcoholism, it could be viral, primary sclerosing. And that's when they're initially diagnosed, usually clinically, they're not showing signs of cirrhosis. You might find it radiographically that they have an imaging studies that's read that they have significant fibrosis that's concerning for cirrhosis. And so you check them, you check their labs, everything seems to be within order. So those are usually patients that are in the compensated stage of cirrhosis. And usually by the 10-year mark after diagnosis of cirrhosis, you'll see that about 60% of patients will have developed some kind of complication from their cirrhosis. And once they develop a complication is when you usually will call them a decompensated liver cirrhotic patient. And any decompensation that they start to develop will significantly affect their prognosis. In fact, their years of survival are most of the time cut by half once they develop any kind of complication. And the four main ones that we usually see in the hospital setting are ascites, hepatic encephalopathy, variceal bleeding, and jaundice. These are the main ones that we're going to talk about in the coming slides. So like we talked, this is a case that I'm going to kind of keep going along as we go along the whole lecture. So you have a patient RS, he's 52. He has a diagnosed alcoholic and HCV cirrhosis. He's now sober. He developed ascites, was placed on the appropriate medications, which are diuretics. He was educated to be on a low salt diet. His family also noticed that he had some changes in his behavior. So he was diagnosed with probably stage 1 of hepatic encephalopathy and started on lactulose. He now presents the ED with diffuse abdominal pain. He has distension and he's confused. So one of the main questions we get asked by family members is, what is the survival of patients like this? So this question, I'm going to kind of lead towards the prognostic models that we use when patients come into the hospital. So like we talked about, over 10 years, usually you'll have some form of hepatic decompensation, and most of the time that's going to be ascites. And there's always risk factors that will push people into hepatic decompensation. And these are things that you guys screen for all the time when patients come in. Let's say a patient comes in with AMS. You're always going to ask them if they took any substances, if they were drinking too much, if there was any new medication. Do they have some kind of infection that's pushed them into this kind of delirium? So these are things that you usually think about in any patient that presents to the ED with, for example, altered mental status. So when you have a decompensation in a liver cirrhotic patient, all of these things apply again, and you always want to rule those out whenever patients come in with any of the 4 decompensations that we talked about. We also talked about how it significantly will reduce your survival without a transplant. So even if you develop any type of complication, your survival is almost cut by half. So the 2 main models that we want to talk about, and I know you guys know about these, is the MELD and the CPT, or the Child-Turcotte-Pugh score. So these prognostic models, they're useful for estimating like disease severity and the survival. And they also are very helpful when you're making medical decisions, when you're guiding patient care. So this is why we use these models so frequently when patients come into the ED with known cirrhosis. The MELD was originally used for predicting mortality after, performing a TIPS procedure. And when they found that it was so accurate, they started using it in cirrhotics, whether it's outpatient setting, inpatient setting, and of course for, placing them on the liver transplant list. So it's actually been found to be quite accurate. And in 2016, this is just based on biochemical markers. It's not based on etiology of cirrhosis. It's not based on any clinical decompensations. It's purely based on biochemical markers. And in 2016, they added the sodium to this because they found that, the severity of hyponatremia correlates almost directly with the severity of cirrhosis, because the serum sodium can reflect the vasodilatory state of a cirrhotic. And that the vasodilatory state is what really leads to a lot of the complications, and we'll kind of get to that in more detail later. So that's when they included the sodium, and it's a good predictor of 30-day mortality, 3-month, 30-day and 90-day mortality. And then we have the CPT. The CPT, I know it's mostly used for surgical, like pre-op evaluation, but it can also be used for prognostic discussions as well. And this one takes biochemical markers, but it also takes clinical decompensation into account. So if we're talking about prognosis, then if you're A and B, you have pretty good prognosis. And then C onwards, it's kind of, your prognosis falls quite a bit. Again, later we'll talk about this in terms of your risk, depending on which class you fall into in post-op complications. But in general, remember that child score A is like a compensated cirrhotic, and B and C are patients that are decompensated. So most of the patients that you're going to see in the hospital, they're going to be B and C patients. Okay. All right. So the first one we're going to talk about is ascites. So ascites is the one that you guys see obviously the most often in the hospital setting. And there's usually a course of how it develops. There's portal hypertension, you get ascites. Then along with the ascites, you start to develop electrolyte abnormalities. And that usually happens when you start treatment for the ascites. Then some patients develop refractory ascites, and eventually that can all lead to hepatorenal syndrome, which is what you really want to prevent the patient from developing. So about 50% of compensated cirrhotics will develop ascites within 10 years. And it's the most common complication that requires hospitalization. Any patient that comes in with a new onset ascites, you have to tap that patient, which I know, is standard practice. And in those patients, you're always going to send, the protein markers. And if the SAG is more than 1.1, it's actually 97% accurate for leaning towards portal hypertension as being the cause of that ascites being there. When it's portal hypertension, you're obviously going to look at the liver and around the liver. And portal hypertension develops when there's any kind of resistance to the portal blood flow. And that causes increase in collaterals to develop. The resistance that we see in cirrhosis is structural resistance because of all the fibrosis that's happening in the liver. You can also have pre-hepatic causes of portal hypertension, and that would be like your portal vein thrombosis. You can also have post-hepatic, like Budd-Chiari. So whenever there's portal hypertension, you guys should just focus on that area anatomically to see what's going on. And as portal hypertension increases, what happens pathophysiologically is that your splanchnic blood flow will increase because there's a release of a bunch of vasodilators. And when there's a release of vasodilators, you get systemic hypotension. Your body naturally reacts by stimulating vasoactive systems. So you get increased plasma volume, you get increased cardiac output, and eventually you just get all of this extra volume. So that's kind of pathophysiologically why this is happening. So the two main things I want you guys to focus on in terms of treatment are the ones that are highlighted, is that you want to do sodium restriction initially, and you want to start these patients on dual diuretics, which is spironolactone and Lasix. There's a specific ratio that we usually use, and you can increment it slowly depending on how the patient is responding to it. And because ultimately we're always worried that hypotension, which is, causing the ascites and this, portal hypertension, all this to get worse, there's always fear that we are going to be pushed into hepatorenal at some point. So it's very important to always keep the kidneys in mind when you're thinking of treating any patient with cirrhosis. So you really want to take them off of any type of nephrotoxic medications like NSAIDs, ACE, ARBs. And then you also want to kind of take them off of anything that will cause hypotension. And this is a little bit of a controversial discussion, which is the beta blockers, non-selective beta blockers, because some of these patients are already on it for variceal bleeds. So, I mean, there is data that suggests that beta blockers in patients with ascites, especially refractory ascites, or SBP, definitely have a higher risk of mortality on beta blockers. So I think there's it depends on like the severity of what you're dealing with, but usually it is recommended. I think it's like a 2C or 2B recommendation to kind of stop the non-selective beta blockers. And of course, this patient now is going to be, because they developed some kind of clinical decompensation, you could actually evaluate them for a liver transplant. Anyone who develops any kind of clinical decompensation, you should evaluate them for liver transplant. What's actually being done, interestingly, I think more in Europe, there was a study done in Italy called the ANSWER study, where they started to infuse albumin in patients that developed ascites weekly. And, it was a small study. There wasn't much that they got out of it, but they did prove in like the few patients that they had in it that there was improved survival. So I think there's a lot more, at least Europe is kind of looking more into this to see if they think that it can eventually act as a disease modifying treatment in patients who have decompensated cirrhosis. But this is not something that is actually standard of practice to do. So back to our patient. So he was on diuretics, which we read because of the ascites, and he starts to develop hyponatremia. So what other management steps would you take in this type of patient now that he's starting to develop complications from being on diuretics? I know that is there a poll? I don't know if there's like a poll system to do this, but does anyone want to take a guess at what you would do next?
Guys, you can unmute yourselves or post in the chat, even if you want to guess. So unanimous option seems to be number 2, a large volume para with albumin repletion.
Yeah. So it actually is that, but it's both. It's large volume paracentesis and it's TIPS, and we're gonna go into that in a little more detail. So now we're getting into the territory of refractory ascites, and this, like we talked about, will push the prognosis even further into being a poor prognosis than just simple ascites. These patients usually are 10% of cirrhotics with ascites will develop refractory ascites, and you define it as them being compliant and unresponsive to a 2-gram sodium diet and high-dose diuretics. The way to actually confirm compliance would be to do a 24-hour urine sodium, which we're not going to get into, but that's important to do to ensure that they're actually compliant. Or it could be that they have clinically significant complications of diuretics, and that can include azotemia, AKI, electrolyte abnormalities. Some of them become encephalopathic. So if they meet those two criteria, they are considered to be refractory. And your treatment options include either doing serial large volume paracenteses or going towards doing a TIPS. And the only definitive treatment, of course, is a liver transplant. So when you compare LVP and TIPS, TIPS has clearly a lot more benefit. There's actually, there's less recurrence of ascites. There's actually better survival. The only adverse thing really that's significant is that it can increase risk of encephalopathy. But there are a lot of restrictions to patients that can get TIPS. And there's a lot of contraindications to doing it. So we usually go for the first option, which is the serial large volume paracenteses. And this, by serial, it means usually every 2 weeks and not less than that. So, you guys have noticed in the hospital that we will give albumin in patients who have large volume paracenteses of more than 5 liters. There's actually no studies to indicate that there's any improvement in survival if it's less than 5 liters to give albumin. But if it is more, there are studies that support improved survival. So you should give albumin in those patients. And then, like we talked about, again, this is another opportunity to decide about whether you want to discontinue non-selective beta blockers, because you don't want to promote hypotension and you don't want to push the patient more towards AKI or hepatorenal. So you have to always question when these patients are on beta blockers about how beneficial it is for them. And this was the large-scale randomized trials that they did for TIPS versus LVP, and there is data to support that TIPS are better. Is better. The limitations for TIPS is that the patient, obviously we already talked about, has to meet the definition of diuretic resistant ascites. Ideally, we have tried large volume paracentesis and they're not tolerating it or they're requiring it more frequently than every 2 weeks. You don't want the patient to be in Child-Pugh class C. The MELD score has to be less than 18. They need to have good social support. They need to have a good functioning heart. So there's a lot of requirements that you need to have in order to actually do TIPS. And what I find helpful is actually to notice what candidates are not good for TIPS. And that would be your class C, MELD more than 18, anyone who has heart failure, anyone who had spontaneous hepatic enceph, and by that I mean they didn't have anything that pushed them into encephalopathy like infection or dehydration. So this is why TIPS kind of becomes a little difficult to perform on everybody, even though the studies show that you actually will do better with TIPS. So back to our patient. The patient has a sodium of 121. His creatinine is 2.1. So we know that he has some resistant ascites. And on the TAP now, they find that he has SBP because he has more than 250 PMNs. So in addition to starting ceftriaxone, what are the things you want to do for this patient?
So again, you guys can unmute yourselves or you can post in the chat whether you would do 1, 2, 3, 4, 5. Nobel is saying 5 with a question mark.
Mm-hmm.
If you would want to do A, B, C.
Yeah, ABC is correct. So an SBP, without a doubt, you want to stop a beta blocker. And then we're going to talk about why we want to give albumin and why we want to check a urine. So this is now territory of hepatorenal syndrome we're getting into. Again, hepatorenal syndrome is a diagnosis of exclusion, but based on just the lab values you're seeing here, you do have a patient that has a creatinine of more than 2, which is considered an AKI. And that's why checking a urine analysis is very important. So the answer is 5, it's ABC. So we stop the beta blocker, you're gonna stop diuretics. You're going to check a urine analysis, urine sodium, and we're going to infuse albumin on days 1 and days 3. And this is purely, to prevent HRS if it hasn't already happened. And obviously, I would call renal on this patient maybe after holding the diuretics for a couple of days and seeing if there's no improvement. But it's not bad to call them if you notice that the patient's already an AKI, because these patients, once they start to develop any kind of organ dysfunction, it's really, prognostically, their mortality just, the risk of mortality increases significantly with any type of further decompensation. So you're going to see hepatorenal syndrome specifically in cirrhotics that have ascites. Okay, so I want you to kind of think about HRS and link it with ascites. And whenever you're managing ascites, I always want you to think about HRS, okay? It's defined as a serum creatinine. You should think about it when the serum creatinine is more than 1.5. You obviously, first thing you're going to do is you're going to stop any beta blockers, you're going to stop the diuretics. And if after 2 days of stopping the diuretics, you still don't see improvement, that is usually a red flag that you're in HRS territory. And usually around that time, we'll start albumin then. After stopping the diuretics for 2 days, if you don't see any improvement, you'll start albumin. And if it doesn't further improve on that, then it obviously at the same time, you're ruling out other causes for it. And if all of that is negative and their creatinine continues to get worse, despite albumin and holding the diuretics, that's when we can say pretty confidently the patient has developed HRS. And what's important to know is that when you send the urine analysis and urine sodium, the urine analysis is quite bland. You're not going to see any protein in there. You're not going to see any blood cells in there or anything like that. So in terms of HRS, briefly, there's 2 types. Type 1 is more rapidly progressive. Sometimes you'll have some level of oliguria. Type 2 is the slower one. It's the one that we see more frequently in the inpatient setting, because some level of it has usually started before the patient comes to the hospital. So usually we're dealing with type 2, and type 2 actually, most of them don't actually have any oliguria. So when you're treating hepatorenal, you have to treat the liver disease, which is difficult in a lot of these cirrhotics because they've reached a point of no return, and the only real treatment for them is liver transplant. So we would do albumin, octreotide, and midodrine is what we're currently doing in the US on the floors. Octreotide acts by, it's a somatostatin analog, so it's going to inhibit endogenous vasodilator release. And midodrine acts as a selective alpha-1 adrenergic agonist. So both of these in conjunction will cause vasoconstriction and try to bring up your blood pressure. In the ICU setting, putting them on a drip is obviously the best form of treatment that you can do for them, and we usually use norepinephrine or vaso. There are studies, and Europe is actually using terlipressin. Terlipressin is an analog of vasopressin, and the studies that they've done so far are very promising for terlipressin. In fact, terlipressin is actually used as a substitute for octreotide and midodrine. It's used in combination with albumin. And there are some newer studies they've done where they actually compare it to albumin, and they find that it's actually better than albumin as well. But we're not using that in the US, and there might be a time where, I'm hopeful that soon they might approve that in the US. In patients that have no return and they need to be on dialysis is always an option. Until they can get a transplant. It's not going to be considered a contraindication if they are on dialysis because of HRS. And in some cases you can do TIPS, but it's not studied very well in terms of using it for HRS. TIPS is mostly used for ascites and variceal bleeding. And then of course, liver transplant is the ultimate type of treatment for that. So SBP in conjunction with HRS, again, they're also very tightly linked. SBP, when patients come in with ascites, your suspicion should be very high if they're febrile, if they're complaining of abdominal pain, and if on exam they have significant tenderness. You should really just start empirically treating them because the mortality risk is so high. And usually, you know, systemically you can treat with ceftriaxone and it will mostly cover all of these patients because you usually have organisms like E. coli or Klebsiella that are causing the SBP. But in certain situations, depending on what prior procedures they've had, if they've had paracentesis in the past or any kind of manipulation, they might have gram-positive organisms in there, including staph. So it's really based on the clinical presentation of whether you want to add vancomycin on top. It's not unreasonable if you can justify that. But mostly we will start with ceftriaxone on these patients. And once you've actually diagnosed it, most of the patients will actually respond with 5 days of treatment. And if they don't, then there is call for sometimes repeating the TAP. But I won't get into that right now. Just remember that usually 5 days is enough and they should respond in 5 days. Like we talked about, you definitely want to stop non-selective beta blockers. And we want to give albumin on day 1 and day 3, especially if there's any sign of them developing AKI, which would be a BUN of more than 30, a creatinine of more than 1, or acute liver failure, which is if the serum bilirubin is above 4. So I know that you're gonna, whenever a lot of our patients come in with GI bleeds in the setting of cirrhosis or hepatic encephalopathy in setting of cirrhosis, you see that we do put these patients on prophylactic antibiotics. And the reason we do that is because all of the decompensations in liver cirrhosis patients, they're all very closely linked to each other. And when you see one decompensation, you're very likely to, it's kind of catapults into all of them, all of those decompensations slowly appearing to you. So you kind of want to keep an eye on all of them. So if someone's coming in with encephalopathy, you always want to tap that patient because you have to rule out SBP as being the cause. Because it often is one of the causes. And even if they don't have SBP, you will put them on prophylactic antibiotics. So I'm just going to go over some of the situations in which we would do that. So like we said, child B or C are usually the ones that come to the hospital. And if they're coming with GI bleeds, I'm sure you've noticed that they're on IV ceftriaxone, and this is the reason that they're on that for. We usually will continue it for a course of 7 days. Let's say they don't come in with GI bleeds, but they come in with, something else. And with encephalopathic patients, we usually will put them on antibiotics. And let's say you do the TAP and you don't see that they have SBP, but if their total protein is less than a certain number, that is still an indication to keep them on prophylactic antibiotics. It does not have to be IV ceftriaxone, it could be an oral antibiotic, and you can usually stop it on discharge. In terms of long-term antibiotics, and again, another primary prevention would be if they meet certain other criteria. So if the total protein in the ascites is less than a certain amount and they also have renal failure or they also have worsening liver failure, their child score is rising, you can argue to put them on long-term prophylactic antibiotics. And obviously for secondary, if there's a prior history of SBP, their risk of recurrence within a year is about 70%. So we usually will put those type of patients on long-term prophylactic antibiotics. Most commonly, when I was a resident, it was Cipro, but there's also Bactrim, there's norfloxacin. And like with any long-term antibiotic use, there's always fear of resistance, and there is documented resistance in certain patients that have had long-term antibiotics. So again, it's like a risk versus benefits type of discussion to have with the patient. All right, so now our patients being treated for SBP, but his encephalopathy is persisting. Lactulose was held because of concern for intravascular volume depletion. Remember, this guy had AKI. So what other options now do you have for treating his encephalopathy if you can't give him lactulose?
So Dio, Joseph Menand, Alex all saying number 2, Rifaximin.
Yeah, Rifaximin's the answer. Again, I know you guys have seen that a lot in the hospital. Rifaximin is actually a really great drug for hepatic encephalopathy. It's not, unfortunately, used as a first line, and it's also very expensive. So getting it for your patient as an outpatient, most of these patients require pre-authorization forms to be filled to actually document that they don't do well on just lactulose before they can get rifaximin as an outpatient. So we're going to talk now about hepatic enceph. So there's different grades of hepatic encephalopathy, and I think that's really important to remember because a lot of us, when these patients come to the ED, if they're not overtly showing signs of somnolence or confusion, we don't ever screen them for hepatic encephalopathy, which is wrong. Whenever your patient comes in and is a documented cirrhotic patient, you should always look for the signs of state of grade 1. And family members are always key in these types of history questions because patients often will not be aware of a lot of the behavioral changes that they're displaying. The only one they might be able to tell you about is sleep. And I always ask my patients about whether they've noticed that they're having difficulty sleeping, or if insomnia is kind of a word that they feel like is they'll often say yes to, and that's new. So it's important to kind of catch it as early as you can before they start to become lethargic and somnolent. And we always will do, like I said, you want to kind of rule out what could have pushed them into that. So you're going to go over all of the things that you usually go over: electrolyte abnormalities, infection, and you'll give lactulose with a goal of 2 to 4 bowel movements. If that's not working, you add on rifaximin. In terms of following the ammonia levels, I think, again, that's very dependent on the clinician in the inpatient setting. If the patient is showing clinical improvement, I usually don't follow the ammonia. Unless the patient's not showing improvement, in which case I would then do an ammonia level. And if the ammonia is dropping appropriately, then we might have to consider some other etiologies as to why the patient is still confused or lethargic. So it really depends on the clinical status of the patient, in my opinion. And there's no need to actually follow blood ammonia levels in patients that have no symptoms. And you do want to maintain their dietary protein intake, because their functional status and their nutrition is very important. It's actually now in the child Turco-Pew, there's also child Pew scoring, and they've actually substituted INR with nutritional status. So the nutritional status is really important in the prognosis of the patient. So you don't want to restrict their protein intake. So now this patient, he's developing all of the things that it would be your worst cirrhotic patient. And this stuff actually happens because, like I said, when one thing goes wrong, all of them kind of start to happen. So he's now developed massive hematemesis. He undergoes an urgent endoscopy and they see grade 3 varices. He has bands placed. And what is the other management you want to do for this patient?
So again, guys, if you want to post in the chat, so Cheryl, Joseph Menen saying number 1, octreotide IV for 72 hours.
Yeah, sorry, the question was accept, and I know I said what you would want to do. So you're right to do octreotide. You will do a vasoconstrictive agent for 72 hours. Some studies say that up to 5 days is also okay to do. We definitely consider tips in these patients. And then we want to continue ceftriaxone for this guy for SBP. But if he did not have SBP, we would give him the dose of SBP prophylaxis in this patient. What you don't want to do is keep a hemoglobin above 10. And I know that this stands for most situations in bleeding. There are a few situations like in sickle cell patients who have acute chest syndrome that you might want to try to aim for a higher hemoglobin, but otherwise across the board, if they're not a cardiac patient, 7 is really what we want to aim for. And you definitely don't want to volume overload these patients because it makes it makes the varices worse, it makes the ascites worse. So variceal bleeding is one of the major causes of death in the inpatient setting of cirrhosis patients. You obviously want to achieve hemostasis and avoid further bleeding in these types of patients. So again, portal hypertension is what eventually causes varices to develop. And there's different types of risk factors that are a little beyond what you guys need to know at the hospitalist level and on the floors, but depending on the size of the varices, the appearance of the varices, and the severity of the liver disease, they're more likely to bleed than not. So these patients usually bleed quite rapidly, and because their blood is thin, they are less likely to clot up on their own. So these are really, these types of bleeds are really scary, and ICU should really be involved, whether they're stable or not, on these cases. And we do want to do an endoscopic treatment for this patient within 12 hours. Of course, you give PRBCs as needed. And then we do the prophylaxis like we talked about. And then we will give a vasoactive medication. Mostly what we use is octreotide for 2 to 5 days. And then you can decide about whether you want to use a non-selective beta blocker, depending on the other symptoms that this patient with decompensated cirrhosis has in the past. In terms of TIPS is something also that we consider in these patients, and we'll talk about that in a little bit. The other things to think about in a bleeder, whether it's the variceal bleeding or if they're bleeding from somewhere else in the setting of cirrhosis, is that you want to kind of optimize all of their coagulopathy. So these patients will have an elevated INR, they'll have thrombocytopenia, and what are your goals to optimize these patients? So you want to give them vitamin K, but sometimes, if the patient's urgently bleeding, you can give them FFP. And you want to transfuse their platelets to keep it above 50. There has been some talk about Tpo receptor agonists. Those are being used mostly in the outpatient setting. They're being used in the preoperative setting of elective surgeries, and they're used to treat thrombocytopenia. So they're usually started like 10 to 14 days before the surgery. They're very, very expensive to buy. So a lot of patients can't even afford to get these medications before surgery. And you really want to try to get these medications in patients that are having major surgery, like cardiac surgery, where their risk of bleeding is so detrimental to them. But in the acute setting, we don't consider Tpo receptor agonists. In terms of TIPS, so TIPS is a procedure, we talked about it for ascites, but it's also commonly used for variceal bleeders. And because we know portal hypertension what leads to these complications, they want to place this shunt to relieve the portal pressure. So what they do is they create a low resistance channel between the hepatic vein and one of the intrahepatic branches of the portal vein. And the tract is it's kept patent by putting a stent there. And then therefore it allows the blood to kind of return to the systemic circulation. But one of the main side effects that we see from this, it can be quite detrimental: hepatic encephalopathy. And in those cases, there have been situations where they've actually like removed the stent and kind of tried to reverse the shunt, because encephalopathy can be so detrimental to some patients if it's not responding to the treatments. But the studies have shown that just like in ascites, TIPS has been beneficial in especially in child C patients, with better outcomes, decreased bleeding, and increased transplant-free survival time. You could consider TIPS preemptively in patients who have come in with GI bleeds, have had treatment for it with vasoactive drugs and endoscopic therapy, and then about 72 hours after it, you can do TIPS on those patients depending on whether they meet the criteria for it, and they have had better outcomes. Right. So back to our patient. He, on endoscopy, was not found to have esophageal varices. He was found to have gastric varices. And even though I've included this question, I don't expect you guys to really remember any of this. I'm going to just jump to the answer. It actually is A, B, and C. There's a few methods that we can use to kind of treat gastric varices. And because we're probably running short on time, I'm not going to really get into any of that. But in terms of vasoactive like drugs, restrictive transfusions, antibiotic prophylaxis, all of that remains the same. This is more of a GI perspective of what you would do if it's gastric versus esophageal varices. So now our guy, he's stabilizing. You've converted him to oral antibiotics. He's probably going to be on it long term to prevent secondaries SBP. His creatinine's getting better. You're deciding about whether you want to start him on Nadolol because he had a GI bleed. And now his MELD is 19. So you've kind of stabilized this patient. He hasn't been drinking for 5 years from the beginning of the scenario. Do you think it's time to put this patient on the liver transplant list? And do you think that he meets the criteria for that? Is the answer mostly yes?
So Lenise is saying yes. Everyone else, I don't know if they already know or they're on the fence. Joseph Menendez seconding it.
Yes, this guy does meet criteria for being on the transplant list. So there's two things you want to look at for transplant list. One is clinical decompensation is one branch, and the other branch is biochemical decompensation. And usually you need a conjunction of both of those. So you want, if they have any kind of clinical decompensation, it doesn't matter which one it is. Encephalopathy, ascites, variceal bleeding, hepatocellular carcinoma, as long as it has not spread anywhere, HRS, hepatopulmonary hypertension, all of these things qualify you to be on the transplant list. I'm not going to get into like acute liver failure because of other toxins, because we're not really talking about that, but specifically with the cirrhotic, if you have any of those, and if you have a MELD score of more than 15, these patients automatically qualify for being on the transplant list. Of course, there's exclusions, which are, a lot of them are common sense ones. AIDS, severe heart failure from some other cause, ongoing drug abuse or alcohol abuse, spread of HCC takes you off of the list, unfortunately. Any other kind of malignancy, any evidence of non-compliance to medications, and unfortunately the last one, lack of adequate social support, is also one of the exclusion criteria for liver transplants. This is just a little pie chart of most of the recipients are actually HCV and malignancy patients, and alcohol is close up there. So just our last topic about preoperative assessment. I know that mostly we use the child Charcot Pew, but MELT can also be used. And from based on like literature, obviously child C is where it gets really scary, where they have 80% mortality risk. But MELD is a good way of predicting 30 and 90-day mortality. ASA also is found to be a good predictor of 7-day mortality. And they also found that in elderly patients, which we don't usually use in ASA criteria or anything, that also contributed to increased mortality in liver cirrhosis patients. That's about the end of the lecture. There's a little bit of a summary. Does anybody have any questions or anything they wanted to discuss?
Thank you so much for that, Dr. Zafar. Like a really excellent overview of like all of the steps and all of the things that we need to know. If anyone has any questions or comments, you can feel free to unmute yourselves or post it in the chat.
Hi, I have a question. When I was wondering, like, when you say like SVP kind of like prophylaxis, how long should we kind of like continue the prophylaxis for?
Yeah. So if you have a GI bleeder, they say that 7 days of prophylaxis is enough. And in those situations, they actually want to keep it IV. But if a patient's coming in with any other decompensation, like I said, in any type of decompensation, you usually want to tap the patient, even if your suspicion of SVP is low. For example, if they come in with hepatic encephalopathy, you have to rule out SVP. Let's say they don't have SVP, but their total protein is less than 1. If their total protein is less than 1, that is an indication to keep the prophylactic on while they're in the inpatient setting. And you can actually stop it once they're discharged.
Okay, and then like, for example, if they come with like decompensated ascites and they have like SVP during that hospitalization and then we discharge them, then like how long should stay?
So that essentially it would be indefinitely because the risk of recurrence is so high. But it also depends on, I think because they're finding that a lot of these patients have increasing resistance patterns that they're noticing. It's really dependent on the patient and the clinician that they're seeing, but essentially it's recommended to keep them on indefinitely.